Let's now shift focus to the child with the unique phenotype. I saw this little girl when she was 7 years old and 4 years before Dada 2 had been described. She had a notable history of blood transfusions in infancy, but no records were available. Since the age of about 2.5 years, she had suffered from recurrent episodes of fevers with bilateral symmetrical large and small joint arthritis that had been treated with NSAID, steroids and methotrexate. While she had been labeled provisionally as a systemic JI by her previous physicians, the pattern of the fever, the low to normal white cell counts, and the remarkable symmetry of deforming affliction of the large and small joints made us realize that we were looking at something different. Several days of OMIM and PubMed searches yielded no matching results, and we finally labeled her as an undifferentiated inflammatory arthritis and eventually put her on etanercept biosimilar after she failed supervised graded methotrexate and methotrexate leflunomide combinations.
Meanwhile, I had joined Dr. Khubchandani's team, and Dr. Girish, a noted geneticist, came visiting our department. We discussed this case with him specifically because he was involved in an international skeletal dysplasia study. When we examined her together, we noticed that her weight and height were below third centile for her age, upper segment to lower segment ratio was normal, she had frontal bossing, retrognathia, hepatosplenomegaly, multiple symmetric active and deformed large and small joints, bilateral hallux valgus, distal laxity of bilateral upper extremities with mild mesomelia of forearms. Dr. Girish agreed to enroll her for the skeletal dysplasia study. WES was sent and her skeletal survey was performed.
The AP radiograph of the pelvis revealed that bilateral hip joint spaces were normal without any erosive changes. However, the femoral heads were looking slightly small and dysplastic for the age, and rest of the bones in the visualized pelvis AP radiograph were looking normal. The bilateral knee AP radiograph showed that the distal femoral and proximal tibial condyles, especially the epiphyseal region, were mildly enlarged and dysplastic with genu-valgum deformity in the bilateral knee joint. If one can notice, there was altered tubulation deformity at the metadiaphyseal region of the distal femur as well as the proximal tibia, as we can see by these arrows. There were multiple deformity in the evaluation of the AP and lateral radiograph of the bilateral foot. The tarsal bones were dysplastic and with deformed multiple intertarsal joints without definite erosive changes. The distal epiphyseal ends of the tibia and fibula also were enlarged and dysplastic. Due to this, the rocker bottom hindfoot valgus, hallux valgus, and metatarsus adductus deformity were there in the bilateral foot. On the evaluation of the bilateral hand radiograph, we found that the carpal bones were dysplastic, small, irregular, and crowded. The distal epiphyseal end of the radius and ulna, they were also looking dysplastic, and there was severe subluxation of the radiocarpal joints on both sides. In addition to these findings, one can see there was hitchhiker thumb deformity like appearance in the left hand, which indicates flexion at the metacarpophalangeal joint and extension at the interphalangeal joint. So to summarize, after the evaluation of the skeletal survey, the deformity were looking like secondary to this kind of dysplastic bone and deforming arthropathy rather than primary inflammatory joint disease.
Meanwhile, she continued to remain asymptomatic on etanercept biosimilar, but her joint deformities of the lower limbs had made weight bearing and locomotion difficult. Thus, we referred her to the orthopedic services, and bilateral triple arthrodesis with tibialis posterior and flexor digitorum longus lengthening procedure was performed. Due to her temporomandibular joint involvement leading to retrognathia, she developed obstructive sleep apnea, which led to daytime sleepiness and sleep hyperhidrosis. Sleep study was performed and night CPAP was started, following which there was drastic improvement in her quality of life and she was more attentive at school. In 2019, we were surprised when excited Dr. Girish called to say that she has a DADA2 mutation.
So, this young lady's story seems to have had a happy ending after all. She continues to be well without fever, rashes, joint pains, and is hematologically normal with normal acute phase reactants. She has grown to some extent, though she still remains shorter and smaller than her peers. She continues to receive etanercept biosimilar regularly. In addition, she receives physiotherapy very regularly at home under the supervision of her mother and is on a CPAP machine for her sleep apnea. She has just finished her 12th grade exams and we are thinking of planning a mandibular advancement surgery for her small mandible and her obstructive sleep apnea.